Welcome back to the Deep Dive. Today we are jumping into Chapter 38 of Focus on Nursing Pharmacology. And this is a really high-stakes one. We're looking at all the drugs and mechanisms used to control blood glucose. So our mission today is pretty straightforward. We're going to distill all this dense material, the pathophysiology, the drug classes, the safety warnings into, clear knowledge you can actually use.
Yeah, this is maybe one of the most crucial areas of pharmacology we ever talk about, diabetes mellitus. It's not just a sugar problem. It's this incredibly complex metabolic disorder that affects how we manage glucose, fat, and protein.
And the stakes for the central nervous system are just massive, right?
It couldn't be higher. You have to remember, the CNS is unique. Its nerves get glucose purely by diffusion. They don't have insulin receptors like other cells. So if your glucose levels swing wildly up or down, the brain suffers immediately. I mean, tight control isn't just a goal, it's an absolute must for brain function.
Okay, so let's start right there with the control center, the pancreas. How does it normally maintain that perfect balance? Who are the key players?
Well, all the heavy lifting happens in the islets of Langerhans. You've got three really crucial cell types there. First are the alpha cells. Think of them as the alarm system. They sense low blood glucose and release glucagon.
And glucagon tells the liver to release sugar. Right?
Yeah, immediately. It signals the liver to break down stored glycogen and get those sugar levels back up. Then you have the beta cells, which are, the most famous ones. They release insulin when glucose is high.
And once that insulin is out in the system, what's its main job? It's the storage hormone, isn't it?
Exactly. Insulin is the key. It binds to receptor sites, and that allows glucose to get into the cells for energy. But it does way more than that. It's the ultimate fuel manager. It helps build glycogen, turns lipids into fat stores, and helps synthesize protein. It's all about building up reserves.
You mentioned there are also some intestinal hormones involved, the incretins. They seem to be a huge deal now, pharmacologically speaking.
Oh, they're fascinating. So GLP-1, glucagon-like polypeptide 1, is made in your GI tract when you eat. And it's like a natural booster for the whole system. It increases insulin, decreases glucagon, slows down your stomach emptying so you feel full.
And it even hits the satiety center in the brain.
It does. The only problem is the body has this enzyme, DPP4, that just degrades it really, really quickly.
So when this whole hormonal system falls apart and you get chronic hyperglycemia, what are the first things we'd see clinically?
You see that classic triad of symptoms. Your cells are starving for glucose, so you get polyphagia, that's excessive hunger, and just general fatigue.
Okay.
At the same time, all that sugar in the blood makes it super concentrated, so the kidneys go into overdrive to filter it out. That's glycosuria.
Glucose in the urine.
Right, and that sugar pulls a ton of water out with it, which leads directly to polydipsia, that intense, constant thirst.
Now let's talk about the long-term damage, because this is really the terror of uncontrolled diabetes. Why does high sugar lead to things like blindness and kidney failure?
It's all structural. Chronic hyperglycemia actually causes the basement membrane in your blood vessels to thicken.
And that's in both the big and small vessels.
Both. Think of the basement membrane as the foundation of the vessel wall. When it thickens, it's like corrosion. It narrows the vessel, restricts blood flow, and less oxygen gets through. And that one mechanism is behind retinopathy in the eyes, neuropathies in the nerves of your feet and legs, and nephropathy in the kidneys.
And the main tool we have to track how well we're preventing that damage is that one key lab value.
The HbA1c, glycosylated hemoglobin. It's so important because red blood cells live about 3 months, so the A1C gives you a 3-month average of blood glucose control.
And the goal for patients with diabetes is?
Less than 7%. It's the single best tool for checking if the therapy is actually working.
Okay, before we dive into the drugs, let's just quickly nail down the difference between type 1 and type 2.
Sure. Type 1 is usually a rapid onset, often after a virus or some autoimmune trigger. It just destroys the beta cells, so you always need insulin replacement. Type 2 is slower. It's usually linked to genetics and obesity. And the problem is twofold. Either you're not making enough insulin, or more often your cells have just become resistant to it.
Which brings us right to insulin therapy. It's the only parenteral agent we use. Let's talk about how complex it is, and especially the safety around the long-acting types.
Insulin is a high-risk medication, no question, especially Eshe. The complexity comes from the different formulations. We have all these versions with different onsets, peaks, and durations.
And you have to match that perfectly to the patient's life.
Exactly. Their meals, their exercise. It has to be precise.
Okay, and that critical safety point, the one about not mixing certain insulins, we have to hammer this home.
This is absolutely non-negotiable. Insulin glargine, which is Lantus, and insulin detamir, Levemir.
Yeah.
You cannot mix them in the same syringe with anything else.
Why not?
Because they're formulated at a specific acidic pH. If you mix them, the pH changes, the solution precipitates, and the time release mechanism is completely destroyed. It becomes unpredictable and ineffective.
Wow. Okay. And when giving it subcutaneously, what's the most important things for nurses to do?
Rotate the sites. You have to. Abdomen, thighs, arms. If you keep injecting in the same spot, you can get lipodystrophy, which are these dents in the skin.
And that scarred tissue won't absorb the insulin properly.
Exactly. Absorption becomes totally inconsistent.
The primary risk we're always watching for is hypoglycemia, and that leads to a really scary drug interaction.
Yes, the one with beta blockers. Every patient on insulin needs to know this. Beta blockers suppress the sympathetic nervous system. So when your blood sugar drops, you normally get those warning signs. The shakiness, the sweating, the fast heart rate.
The SNS response.
Right. Beta blockers mask all of that. They hide the warning signs, and the patient might not know they're severely hypoglycemic until they're already confused or unconscious. It's incredibly dangerous.
All right, now we get to where things have really exploded. For type 2 patients, the oral agents and other injectables. Let's start with the oldest class, the sulfonylureas.
Right, so drugs like chlorpropamide or gleburide, these are called secretagogues. Their mechanism is, well, it's pretty simple. They just stimulate the beta cells to secrete more insulin.
Which sounds effective, but also a bit like a blunt instrument.
It is, and that's their strength and their weakness. It lowers glucose, but it also carries a huge risk of hypoglycemia because it's forcing that insulin release no matter what the blood sugar level is.
And there's a cardiovascular risk too, right?
Yes, especially with the older first-generation agents. A potential increased risk of CV mortality, which is a big reason they aren't really a first-line choice anymore.
Which brings us to the current standard of care, metformin. What makes it the preferred choice, even with its own risks?
Metformin was a total game changer. Its main job is to decrease glucose production by the liver.
Ah, so it's not stimulating the pancreas.
Exactly, and that's the key. Since it doesn't force insulin release when you use it by itself, it very rarely causes hypoglycemia. That's a massive advantage over the sulfonylureas.
But it does have that one serious risk.
Lactic acidosis. It's a risk, especially in patients with kidney problems. But clinically, the risk is lower than the constant daily threat of hypoglycemia. It's also the only oral agent approved for kids 10 and older.
Okay, next up, the drugs that tackle insulin resistance head-on. The thiazolinate endiones, like pioglitazone.
Right, these are used to increase the cell's sensitivity to the insulin that's already there. But the warnings here are severe. There's a black box warning about an increased risk of heart failure. They are absolutely contraindicated in anyone with moderate to severe heart failure.
And there's a cancer risk too.
With pioglitazone, yes. The source material links it to an increased risk of bladder cancer if it's used for more than a year. So very powerful drugs, but they come with significant risks.
Now, for the most mechanically unique class, I think, the SGLT2 inhibitors. Canagliflozin, they don't even touch the pancreas.
They're brilliant, really. They work entirely in the kidney. They block a transporter that normally reabsorbs glucose back into the blood.
Yeah.
By blocking it, they force huge amounts of glucose to just get spilled out into the urine.
Cure glycosuria.
Exactly. It lowers blood sugar really effectively, but the side effects come directly from that action.
Right, so you have a urinary tract full of sugar, which means...
high risk for UTIs and genital fungal infections. It creates the perfect breeding ground.
And the second risk.
Dehydration. That big glucose molecule drags a lot of water out with it, so patients are at risk for dehydration and, subsequent hypotension.
Okay, let's round out the drugs by coming back to those incretins. We have two ways to play with them now, right?
We do. First, you have the GLP-1 receptor agonists, like liraglutide. They're injectable, and they're basically synthetic incretins that the body can't break down quickly. So they hang around and do all that good stuff, increase insulin, decrease glucagon, promote satiety.
And the other way is oral.
Right. The DPC4 inhibitors, like sitagliptin, they take a different approach. They just block the enzyme DPP4 that breaks down your body's own natural GLP-1.
So both are boosting that incretin effect.
Correct. But both carry a risk of pancreatitis. And we have to mention the black box warning for liraglutide and semaglutide about thyroid C-cell tumors that were seen in animal studies.
With so many different mechanisms, nursing insight is just...
it's everything. Let's talk about that clinical scenario with stress and glucose.
This is such a classic clinical trap. Say you have a patient with severe trauma or a major infection. Their body floods with fight-or-flight hormones, cortisol, epinephrine. These hormones are designed to skyrocket blood glucose, sometimes into the 300s or 400s, to fuel survival.
So a nurse sees that number, and their first instinct is to grab the insulin.
Right. But if you treat that number too aggressively, especially in someone who isn't diabetic, you risk causing severe hypoglycemia the second that stressor goes away and the hormone levels drop. So the takeaway is that some hyperglycemia during acute stress is actually an expected protective response. You have to be careful not to create that dangerous high-low swing.
Precisely. You monitor carefully, but you have to respect the body's stress response.
So if we just visualize the two extremes, hypo versus hyper laws, what are the key signs a nurse needs to spot instantly?
It's life-saving to know the difference. For hypoglycemia, under 70 think SNS response, the patient is pale, cool, clammy.
Shaky, nervous, confused.
Exactly. For hyperglycemia, think metabolic dysfunction. The patient is warm, dry, dehydrated. They might have that fruity ketone breath and those deep, labored Kussmaul respirations as their body tries to blow off acid.
And what about across the lifespan? Any key differences?
Definitely. With kids, especially infants, dosing is a huge challenge. Insulin often needs to be diluted. With teens, you're fighting adherence issues.
And in pregnancy?
Insulin is the drug of choice. Absolutely. It does not cross the placenta, so it's safe for the fetus, unlike a lot of the oral agents.
And older adults?
You're watching for renal and hepatic impairment, which affects how they clear these drugs. And, physical limits like poor eyesight might mean you need to use pre-drawn syringes to ensure they're dosing accurately.
Okay, last thing, the emergency plan. When the pendulum swings too far into hypoglycemia, what do we have to reverse it?
For a severe emergency reaction, the go-to parenteral agent is glucagon. You inject it, and it works fast by telling the liver to dump its glycogen stores.
And for someone who is still conscious?
You can use over-the-counter oral glucose like tablets or gels. There's also an oral agent, diazoxide, for more persistent issues, but you have to watch for allergies there.
Wow, we have covered a huge amount of ground here. From the micro-level action of incretins to the systemic danger of a thickening basement membrane. I think the key takeaway for you listening is that blood glucose control is this constant dynamic balancing act.
It really is. It's diet, it's exercise, and it's a very precise drug regimen that needs constant monitoring. This whole review raises a really interesting question for the future. We now have these two big strategies. We have drugs that leverage the body's own intelligence, like the GLP-1 agonists that mimic natural signals.
Right.
And then we have drugs that work by kind of brute force, like the SGLT2 inhibitors that just mechanically block reabsorption. So the question is, which approach, the intelligence-based or the force-based, is ultimately going to be safer and more sustainable for managing a lifelong disease? And what trade-offs are we making when we choose one over the other?
The deeply complex question. And it really reminds us why this chapter is so central to pharmacology today. Thank you for joining us for this deep dive into blood glucose management. Continue exploring these critical mechanisms.